So this next position that we're going to talk about is prone position. That's when your patient is face down. There are a lot of things to consider when going prone. It is a dangerous position. There's risk of them falling off the table. There's risk of desatting, all kinds of stuff. People do not like to be prone, especially for a long period of time. So you need to make sure you're very, very diligent in positioning them correctly so that they're comfortable. If the patient's awake, they can help you do this, but typically, at least where we are, the patient is going to be asleep. You need to know what kind of surgery you're doing and surgeon preference to know where to place certain things. If you're doing a spine surgery, you don't want to put a safety strap right across the back because obviously they're going to be operating there. If they're doing a cervical spine, then maybe you can put a safety strap up here on their back. I usually start with my safety strap across their legs in the middle of the thighs, not too tight, because I don't want to compress and injure any nerves running through the legs. I don't want it to slide down and compress the back of the knee and cause some perineal nerve injury. So I'm going to start with the head and kind of go through the different considerations. So they are prone, so most likely they were put to sleep on the stretcher. It'd be very difficult to put them to sleep upside down. So put them to sleep on the stretcher, and then you move them over. You move them to the edge of the stretcher and then flip them over onto the bed. It takes at least 4 people, right? All patient movement is led by the CRNA, anesthesia, whatever, MDA, anesthesia resident, whatever you have, because they're securing the airway. So they're in charge of moving the patient, counting to 3 and then flipping them, okay? There's a person on this side to catch them. There's a person on this side to flip them. There's a person on the legs, and then anesthesia at the head. So this is a prone view headrest. It has a little plate with a mirror on it so that the anesthesia provider can see up and make sure the tube is still in the correct place. And then it has this disposable foam where the patient's face goes, and this plastic cover that's reusable. Next would be the arms. So you might have your arms tucked. If your arms are tucked, you want to make sure that you had put a draw sheet on the bed, and that way you can put their arms going down their side. This time, since they're face down, it would be thumb down. I would pad my elbow and my wrists on both sides. I take my draw sheet. This is how we do it. You just take it like this and tape it. We do this position usually when we're working on the cervical spine, because the surgeons are going to be up here and they want the arms out of the way. They don't want the arms up. That's one consideration. If you're going to put arms up, say they're working on the lumbar spine, this arm would be in the way. So what we would do, you can't just take someone's arm and throw it up. You might dislocate it or injure it. There's a natural movement, which is the swing. Swing straight up. So we're going down, coming down like this, and we're swinging straight up, like that. And then I'd have somebody else help me put the arm board on. Put it on a little differently. I'm going to swing this arm board towards the head, like that. And then I have my arms like that, and I pad them and support them under the shoulder, under the elbow, and the hand, and I put a safety strap around them. Typically, anesthesia takes care of this, but you also need to double check as the nurse. Okay. Moving down to the abdomen area. Right now, I'm using what's called a Wilson frame. This is an old one that's a gel one. The new ones have plastic bases that you can strap to the bed, and then they have a gel pad on the top that the patient goes over. This dummy is not really a normal size of a person, so they're not laying on this correctly. But your doctor, your anesthesia provider, It'll make sure that the patient is positioned correctly. You don't want them too far down, you don't want them too far up. So you want to make sure that you have the correct positioner for surgeon preference and type of surgery you're doing before you put the patient on the bed. And make sure that it's secured. And you have a draw sheet over it if you need it. This is also, take this draw sheet, lift it up and move the patient a lot easier than trying to just get your hands under the patient. We already talked about safety strap placement. I've used the patient gown to go in between the safety strap and the legs. And also, like I said, put it somewhere up here across the back, depending on where we're operating. Next would be the knees. I want the knees supported and foamed and padded, so I've got foam under the knees. We're gonna have the legs bent up. I've built up my legs to where my feet are gonna be able to hang. So I did use blankets to build this up. Blankets are not an acceptable positioning device. They're not made to position patients and support them correctly. You can still get pressure injuries with a bunch of blankets. But I used the blankets to build it up, and then I used some foam because jump pad over the top, so my patient's not actually touching the blanket. I want their foot hanging off and make sure that their toes are not touching anything and that their foot's in a neutral position. Other considerations is bovie pad placement. You don't want to put your bovie pad on until you position your patient because you don't want it on the underside and get, wadded up or whatever. You want to be able to adjust it if you need to throughout the case. So a good place would be on the back of the thigh. Depending on where you're operating, could be on the back. Could be, if you had to, you could put it on the upper arm. That's not ideal, but you could. The other thing is to make sure that all their lines are secured before you flip them and move them. If they have a Foley in, make sure it's brought across and hanging at the foot of the head or whichever one you prefer. You also want to make sure that their lines are not kinked and tangled and under them. You want to free all of that. You want to make sure they're not laying on anything, like any wires or anything that could cause some type of skin injury. Other types of positioners you could use, there's a bunch of prone positioners. This is a Wilson frame. You could use gel rolls that are made, which you just put 2 gel rolls like that, and the patient would lay on them. You could use pillows if the patient is awake and can support themselves. They make a special table called an Open Jackson table that's made for prone positioning. It's typically what the spine surgeons like to use. It has attachments to support each area of the patient. So just depends on what your facility uses, what your surgeon preference is.